how to interpret electrolyte blood results to identify abnormalities. This peer-reviewed article, aimed at advanced practitioners, reviews the basic physiology of 4 significant electrolytes, their abnormalities, and the consequences of electrolyte imbalance. It is written by Deborah Slade, Senior Lecturer in Advanced Practice, Oxford Brookes University, and read to you using an automated voice. Therefore, some of the words and phrases may not be as you would usually expect to hear them. Introduction. Electrolytes are minerals that have an electrical charge when dissolved in water body fluids, for example, blood, urine, and cells. These negatively charged anions and positively charged cations electrons are vital for cellular reactions and functions. Electrolytes maintain acid-base balance, electrical neutrality in cells, generation conduction of action potentials in nerves and muscles, fluid regulation and blood clotting. The body obtains electrolytes from food and fluids. Normal target ranges for electrolytes are narrow, and slight abnormalities can devastate bodily functions. Electrolyte blood results in biochemistry testing, convey molecular-level changes in the body's cellular processes, giving understanding of conditions and diseases such as dehydration, diabetes mellitus, kidney dysfunction, and acid-base imbalances. This article reviews the electrolytes sodium, Na, potassium, K, calcium, Ca, and magnesium, Mg, as measured in a blood serum test, their basic physiology, abnormalities, and the consequences of electrolyte imbalance. Advanced practitioners must analyze electrolyte results alongside patient history, clinical presentation, and examination findings to understand the patient's condition, guide further diagnostic investigations, and develop management strategies. Normal ranges and imbalances of sodium, potassium, calcium, and magnesium can be found with the article published on nursingtimes.net. All electrolytes must be considered together as they affect each other. Sodium Na. Sodium maintains blood plasma volume, extracellular fluid, acid-base balance, transmission of nerve impulses, and normal cell function. Sodium is the principal extracellular positively charged cation, Na+, and a major contributor to the osmolality, particle concentration dissolved in a fluid, of the blood. Around 60% of body weight is water, around 40 litres in an adult weighing 70 kilograms. In health, total body sodium is constant because essentially sodium excretion matches food and fluid intake. However, the gastrointestinal GI tract is often a major route of sodium loss. Hypernatremia. Hypernatremia is when sodium in the blood is too high due to reduced fluid intake or excess fluid loss. Hypernatremia is less common than hyponatremia, low blood sodium, but more clinically significant if it develops rapidly, mortality greater than 50%. The clinical presentation is dehydration symptoms, headache, thirst, dry mouth, lips, sunken eyes, concentrated urine. Causes are water depletion, although total body sodium is constant, decreased water intake, and continued insensible water losses through the skin and lungs led to decreased extracellular fluid volume. Examples include reduced oral fluid intake, especially in infants or older people, and diaphoresis, excessive sweating, with fever or heat stroke. Patients with diabetes insipidus lose too much water in the urine due to the impaired release of antidiuretic hormone, ADH, from the pituitary gland. This prevents the renal tubules from conserving water, causing hyponatremia, seen in individuals with traumatic brain injury or pituitary tumours. Nephrogenic diabetes insipidus occurs when renal tubule cells fail to respond to ADH due to lithium use, medication for mood disorders, or hypokalemia, low potassium levels. Treating the underlying cause of hyponatremia is paramount alongside replacement fluids, water and sodium depletion, Deficits of water over sodium, when the body loses more water than sodium, may occur with increased urine production osmotic diuresis due to glucosuria, excess glucose in the urine, in patients with diabetes mellitus. Similarly, urea diuresis occurs with high-protein feeds, diets, without adequate water supplementation. Deficits of water greater than sodium also occurs with burn injuries, excessive sweating and excess watery diarrhea. Increased sodium content of extracellular fluid. This can occur with intravenous (IV) administration of sodium bicarbonate, or NaHCO3, a concentration of 8.4%, 1,000 millimoles per litre of sodium, used to treat acidosis, may be mitigated by considering a less concentrated solution of NaHCO3, 1.26%, 150 millimoles per litre sodium. Excess secretion of aldosterone, a steroid hormone controlling serum sodium and potassium, causes sodium retention in renal tubules. Hyponatremia occurs in patients with benign tumours on the adrenal glands. Conn's syndrome, adrenal glands make too much aldosterone, and renal disease. Hyponatremia. A decrease in serum sodium levels relative to water is called hyponatremia and causes dilution of body fluids, low osmolality. Up to 40% of inpatients can have serum sodium less than 138 millimoles per litre. To excrete excess water, the osmoregulatory hypothalamus in the brain stimulates the pituitary gland to secrete less ADH, to regulate healthy nephrons, to excrete water and reabsorb sodium. Presenting symptoms of hyponatremia can be found in the online article. Causes include non-oedematous hyponatremia, an increase in body fluid with the total body sodium remaining constant. One example is syndrome of inappropriate antidiuretic hormone, SIADH, in which not enough water is excreted, causing very concentrated urine. However, this condition shows no signs of fluid volume excess, blood pressure is normal, normotensive, and glomerular filtration rate, GFR, serum urea, and creatinine, measures of kidney function, remain in range. SIADH may occur in patients with pneumonia, subphrenic abscess, fluid accumulation between the diaphragm, liver, and spleen, malignancy, and abdominal surgery. It can also be induced by drugs, such as thiazide diuretics and chlorpropamide. Non-oedematous hyponatremia can also be caused by drinking too much water, intoxication, to try to rehydrate after a long period of not drinking. It can also occur after IV 5% glucose infusions. Glucose is metabolized, leaving free water. Sodium loss. Hypertension and sodium loss can occur due to chronic or acute GI losses, such as vomiting or watery diarrhea. Increased sodium excretion and extracellular fluid depletion leads to thirst, dyspnoea, vomiting, abdominal cramps, confusion, and lethargy. Individuals show signs of dehydration, such as sunken eyes, dry tongue, and buccal mucosa, soft, moist lining of the mouth, postural hypotension, and tachycardia. Life-threatening sodium depletion may present with serum sodium in the normal range, so the patient's history and clinical signs must be prioritized. Potassium, K. Potassium is the principal positively charged ion cation, K+, in the intracellular fluid, 98% of total body potassium in the intracellular space, and 2% in the extracellular space. As the body cannot conserve potassium, it must be ingested daily in the diet. Cellular uptake of potassium is stimulated by insulin. Sodium and potassium have a reciprocal relationship. The kidneys reabsorb sodium and excrete potassium in response to aldosterone secretion. Small changes in potassium concentration can affect the excitability of nerve and muscle tissue. For example, The heart's vulnerability to potassium fluctuations can cause life-threatening arrhythmias. Extracellular fluid gains potassium when cells are destroyed, and intracellular potassium is released, and also when potassium shifts from intracellular fluid to extracellular fluid. For example, in acidosis, which redistributes potassium from the intracellular to extracellular space in exchange for hydrogen ions, H+. Once the cause of acidosis is corrected, potassium is transported back to the intracellular space, reducing potassium in the blood. Caution is therefore needed with potassium replacement management during acidosis. The kidneys have no mechanism to combat potassium loss as it is excreted, even when plasma levels are low. Hyperkalemia. Hyperkalemia is when the serum or plasma K+ level is above the upper limits of normal. In patients at risk of hyperkalemia, it is important to be aware of presenting signs as given in the online article. Causes include renal failure. Hyperkalemia can occur in a variety of patient conditions. For example, poor excretion of potassium because of low GFR, kidney damage due to diabetes mellitus, systemic lupus, erythematosus, and sickle cell disease. Premature babies are at high risk of hyperkalemia within 48 hours of birth because of their immature renal function. Older adults are at risk due to deteriorating renal function, reduced renal blood flow, reduced GFR, reduced oral intake of potassium, and decreasing plasma renin and aldosterone, which reduce excretion of potassium. Older adults with polypharmacy, regular simultaneous use of 5 or more medications, are more likely to take medications that may interfere with potassium excretion, such as non-steroidal anti-inflammatory drugs, angiotensin-converting enzyme inhibitors, and potassium-sparing diuretics. Subcutaneous heparin therapy. This can interfere with aldosterone production, thereby decreasing potassium excretion. Addison's disease. Both Addison's disease, reduced aldosterone excretion, hypoaldosteronism, and aldosterone antagonist drugs, for example, spironolactone, decrease potassium excretion. Cell damage. Potassium release from intracellular fluid in patients with burns, rhabdomyolysis, muscle tissue breakdown resulting in the release of toxic components into the bloodstream and kidneys. Trauma, malignancy, hemolysis and chemotherapy. Blood transfusions with stored blood. These may cause hyperkalemia when potassium leaks from cells due to failure of the Na plus K plus ATPase pump, which transports Na plus and K plus ions across cell membranes against their concentration gradients. The potassium plasma level may increase by 0.5 to 1.0 millimoles per litre per day of refrigerated blood storage. Insulin deficiency. Low cellular uptake of potassium results in hyperkalemia. Hypokalemia. Hypokalemia is when potassium in the blood becomes too low due to inadequate intake or excess loss. Clinical features include muscle and heart symptoms. Causes include GI losses. For example, due to prolonged vomiting, loss of gastric acid leads to alkalemia. Diarrhea, quick transit through the colon prevents absorption. Surgical fistula and laxative misuse. Renal losses, for example due to renal disease, administration of diuretics, thiazides and frusemide. Hyperaldosteronism, excess potassium is excreted. Alcoholism, a newly transplanted kidney. Glycosuria, high glucose in the urine. Osmotic diuresis, magnesium depletion and high stress, drug-induced hypokalemia. This may occur with thiazide diuretics, corticosteroids, and adrenaline. Alkalosis. This stimulates a shift of K+ from the extracellular to intracellular space in exchange for H+. Therefore, correcting the cause of alkalosis is essential when considering K+ replacement therapy. IV dextrose administration. Large amounts may cause increased endogenous insulin release and hence hypokalemia. Insulin stimulates cellular potassium uptake. Reduced dietary intake. Reduced intake of potassium-rich food such as chocolate, dried fruit, nuts, seeds, fruit, oranges, bananas, apricots, meat and vegetables, beans, potatoes, mushrooms, tomatoes and celery. Insufficient oral intake. Administration of potassium-deficient IV fluid and lack of potassium supplement in total parenteral nutrition will predispose a patient to hypokalemia. Calcium, Ca. Approximately 99% of calcium is stored in bones and teeth and 1% in the extracellular fluid and soft tissue. Some bone is reabsorbed daily and calcium is returned to the extracellular fluid. To maintain calcium balance, an equal amount of bone formation must occur. Calcium maintains cell structure and function, helps maintain cell membrane stability and long-term permeability control, facilitates nerve impulse transmission for contraction of cardiac, smooth and skeletal muscle, and is integral to the clotting cascade and release of certain hormones. Calcium binding. Serum calcium concentration is kept within a very narrow range. Approximately 45% is bound to plasma proteins, primarily albumin, 15% to small anions, such as PO43 and citrate, and 40% is in free or ionized state, Ca++, which is the active form. As such, reduced serum albumin, hypoalbuminemia, leads to reduced bound serum calcium, but the level of free ionized Ca++ is unaffected. Acid-base disturbances affect the binding capacity of calcium to albumin and exchange of Ca++ and H+ ions between the intracellular and extracellular space. If blood pH rises, alkalosis, more calcium binds with proteins, so the level of free/ionized Ca++ drops, and the patient with alkalosis develops hypocalcemia. However, when blood pH drops, acidosis, less calcium binds with proteins and free ionized Ca rises, causing hypercalcemia. A special equipment is required to measure free ionized Ca++. Biochemistry tests usually measure total serum calcium concentration, corrected for the blood albumin level. Homeostasis. Calcium is absorbed across the intestinal mucosa. Net absorption must equal daily urinary loss to maintain homeostasis. Hormones regulate calcium transport in the gut, kidneys and bone. These are primarily parathyroid hormone, PTH, vitamin D3 and calcitonin. PTH maintains calcium within tight limits for nerve function, cell membrane permeability, muscle contraction, and glandular secretion. As PTH is dependent on free/ionized Ca++, patients with low albumin are not hypocalcemic, low blood calcium, and the laboratory adjusts the calcium level to reflect normal albumin. PTH is secreted in response to low free/ionized Ca++ and causes bone resorption, liberating calcium from bone and promoting reabsorption in kidney tubules. Consequently, increased PTH secretion in response to low free ionized K++ can lead to bone disease if left untreated. Calcitonin, released by the thyroid gland, acts transiently as an antagonist to PTH. It inhibits bone resorption, decreasing gut absorption and promoting excretion of calcium. Gut absorption of calcium by sterile hormones depends on vitamin D and PTH. Vitamin D also promotes calcium resorption from bone, as well as calcium kidney reabsorption, to raise serum total calcium levels. Hypercalcemia. Raised levels of serum/total calcium, hypercalcemia, are more common than hypocalcemia. Patients may be asymptomatic in the early stages, but clinical presentation in severe cases can include neurological and psychological signs, muscle weakness leading to cardiac and gut problems, kidney failure, and bone pain. Causes include increased calcium resorption from bone. This is a primary cause due to hyperparathyroidism, increased serum PTH levels. Hyperparathyroidism can be due to familial predisposition, abnormalities in several potential genes, or a parathyroid adenoma tumor that secretes PTH, independent of feedback control of free/ionized Ka++, hypercalcemia of malignancy. This occurs when tumors invade and destroy bone, releasing a PTH-related protein that raises serum total calcium levels. For example, squamous cell carcinoma of lung, myeloma, a cancer of the bone marrow, Hodgkin's lymphoma, renal cell carcinoma, or breast cancer. Increased calcium absorption, reduced excretion, increased absorption in the GI tract, and reduced excretion from the kidneys. Inappropriate vitamin D or metabolites when treating renal disease or hypoparathyroidism. Hyperthyroidism, raising levels of thyroid hormones. This can accelerate bone turnover, especially osteoclastic activity, the breaking down of bone, which is essential for bone modeling and growth. This leads to raised serum total calcium levels from increased bone resorption, immobilization, or multiple fractures. These can increase calcium release from bone, especially in people with Paget's disease, in whom thickened, disorganized bone structure is prone to fracture. Hyperphosphatemia, low phosphate, PO4. This increases free/ionized K+, because calcium has an inverse relationship with PO4, with PTH regulating levels of calcium and PO4 in the blood. Calcium therapy, routine calcium-containing solutions given during cardiac surgery, abuse of certain antacids, calcium carbonate, side effects of lithium or thiazide diuretics that reduce renal excretion of free ionized Ka++, and increased vitamin A, increases bone resorption, can all predispose a patient to hypercalcemia. These should be checked when biochemistry results show a raised serum total calcium level. Hypocalcemia. Characterized by low levels of serum total calcium, mild cases can be asymptomatic. However, if hypocalcemia is severe, presenting symptoms can include neuromuscular and cardiac symptoms. Causes include low serum albumin. This occurs with low blood albumin levels because most of the body's calcium is bound to albumin. Therefore, serum/total calcium should always be corrected for the albumin level before hypocalcemia is diagnosed. There is an around 0.25 millimoles per litre drop in serum total calcium concentration for every 10 grams per litre reduction in the serum albumin concentration. This can be caused by cirrhosis, nephrosis, malnutrition, burns, chronic illness and sepsis. Poor dietary intake, for example, a lack of green leafy vegetables, dairy, whole grains, nuts and legumes. Most at-risk individuals are older adults, and postmenopausal women lacking estrogen reduces calcium absorption. Alcoholics are especially prone due to poor diet, poor calcium absorption, and low magnesium levels that induce PTH resistance, vitamin D deficiency due to malabsorption, inadequate diet, and little exposure to sunlight. Certain anticonvulsant drugs, for example, phenytoin, sodium valproate, interfere with vitamin D metabolism, leading to osteomalacia, softening of the bones, in adults and rickets in children. Increased intestinal activity. When this leads to malabsorption or loss of calcium salts in feces, hypocalcemia occurs. Examples include patients with persistent diarrhea, laxative misuse, chronic malabsorption, or pancreatic insufficiency, reduced activity, inactivity. This can lead to a loss of calcium from bones. Serum, total calcium levels may be normal. In the long term, this may accelerate the development of osteoporosis, hypoparathyroidism, decreased serum PTH levels. This can be due to damaged parathyroid glands, post-surgery, or due to autoimmune effects, abnormal regulation of PTH production and secretion, or abnormal parathyroid gland development. Post-surgery damage is the most common reason for hypoparathyroidism. Low PTH as a cause of hypocalcemia is determined by repeated serum total calcium levels measured at least 2 weeks apart, combined with inappropriately low PTH levels. Magnesium deficiency. As normal magnesium levels are needed to produce parathyroid hormone, magnesium deficiency can decrease calcium absorption in the gut and kidneys. The aminoglycoside antibiotic, gentamicin, lowers serum magnesium and may decrease calcium resorption from bone. Substantial blood transfusion. This can cause an acute decline in free ionized K++ due to calcium binding with citrate, used as an anticoagulant in stored blood, which renders it unavailable for use. At risk are children and patients receiving a massive transfusion. Magnesium, Mag. Mg++, the active form of magnesium, is the fourth most abundant cation in the human body and the second most abundant intracellular cation after PO43. Magnesium tends to be bound to albumin or other substances. Mg++ cannot be measured, so biochemistry laboratory results will reflect the total circulating amount of magnesium, making it important to also measure serum albumin levels. Magnesium is a cofactor in around 300 enzyme systems that control diverse biochemical reactions in the body, including protein synthesis, muscle and nerve function through cell membrane transport of potassium and calcium, blood glucose control and glycolysis, splitting of glucose into 2 pyruvate molecules, aerobic oxidative metabolism, chemical process using oxygen to produce energy from carbohydrates. Magnesium also facilitates normal function of the cardiac and vascular systems, affecting blood pressure control, vasodilation, and contractility of cardiac muscle. It is an integral part of chlorophyll, so green leafy vegetables are a dietary source. 30% is absorbed from the small intestine and distributed to metabolically active tissue. Hypermagnesemia. A high level of serum magnesium, hypermagnesemia, is uncommon, but may be seen in renal failure, dysfunction, untreated DKA, or in patients receiving magnesium-containing antacids, laxatives, supplements, and rectal enemas. Clinical features include cardiovascular, cardiac, respiratory, and neurological manifestations, as indicated in the online article. Hypomagnesemia. Low magnesium, hypomagnesemia, when severe, may cause hypoparathyroidism and hypocalcemia. Patients with vascular disease and hypomagnesemia are at higher risk of strokes. The condition affects around 10% of critically ill hospitalized patients, mainly due to GI and/or renal disorders, and may lead to secondary hypokalemia and hypocalcemia, causing severe neuromuscular and cardiovascular manifestations. Symptoms of hypomagnesemia are similar to those of hypocalcemia and hypokalemia, and include impaired neuromuscular and cardiac function and CVS symptoms. Causes include dietary insufficiency and intestinal malabsorption, for example, due to severe vomiting, diarrhea or fistula losses, and following prolonged nasogastric aspiration or suction. Alcohol overuse triggers the kidneys to excrete more magnesium, exacerbated by poor diet and vomiting. Insufficient oral intake, for example, in IV fluid therapy, total parenteral nutrition delivered intravenously, or enteral feeding. Compromised gut absorption, excess calcium and PO4 in the GI tract impair magnesium absorption and may be seen in patients with infection, inflammation, surgery, and cancer. Pancreatitis. Magnesium forms soaps, with fatty acids taking magnesium out of the circulation, leading to low serum levels. Loss from the kidneys, for example, in patients with osmotic diuresis due to hyperglycemia, DKA, prolonged use of loop or thiazide diuretics, glomerulonephritis, inflammation, damage to the glomeruli or filtering part of the kidneys, pyelonephritis, kidney infection, renal tubular acidosis, or impaired renal reabsorption caused by anti-cancer cytotoxic drug therapy, excessive loss of body fluids, for example due to burns, chronic diarrhea, or breastfeeding. Conclusion. Accurate interpretation of electrolyte results is crucial, as imbalances can have significant, sometimes life-threatening implications, particularly in acute, critically ill patients or those who have complex medical conditions. It is used to monitor organ function, guide fluid management, diagnose underlying conditions, prevent complications, and monitor responses to therapies, and recognize and manage critical situations. The full version of this article, with references and illustrations, can be found at nursingtimes.net under the category Assessment Skills, along with our AI search facility, Ask Nursing Times, which allows you to explore the subject further. Subscribers to Nursing Times have unlimited access to all our current and archived clinical articles, including a range of online learning units on fundamental aspects of nursing to contribute towards your continuing professional development and revalidation requirements. Thank you for listening.